in the future. So I had a 55-year-old female. She was detoxing from alcohol, drinking approximately 24 beers daily over the last 5 years. So she showed up and we started her on our detox protocol. She was started on a Librium taper. So usually we do a Librium taper over the course of 7 days. The reason we choose Librium, it's not euphorogenic, so they don't get a lot of good feeling from it, and it's very long acting, very predictable. So we started her on that taper and we noticed that it was not touching the detox symptoms at all. She was still very tremulous. She pointed out that she felt like the detox symptoms would resolve for a little bit, a few minutes, and then they would come right back. And we noticed with the tremors, CWA stayed elevated. As a practitioner, if you're using a benzodiazepine and it's not having the intended effect on the withdrawal symptoms, you ask yourself a couple questions. Is it hepatic impairment, right? So we know that hepatic impairment, Ativan would be the most suitable option, right? But sometimes we don't know that. If they're an older patient, maybe we go there anyway, just because there could be hepatic impairment, and older individuals tend to tolerate Ativan better. But we didn't know that because she came in, we didn't have any labs, we don't know if there's hepatic impairment. And the next thing we look at is medical history. So looking at her medical history, I actually noticed that she had a bowel resection. And that's important because Librium is broken down and it needs time to go through the GI tract. So if there is a resection in there, then the time is going to be accelerated right through that GI system since there is a resect. And depending on where it is, that can have a very important influence and role in how that medication is metabolized and ultimately how the detox symptoms present. So we went ahead and switched the patient to Ativan, right? Because we know that Ativan is more hydrophilic, whereas Librium is more lipophilic, and there's not that surface area with the mucosa to help break down the Librium, right? We have less surface area, we have less time in the GI tract, and the patient is doing well. So just something to think about. What I was taught by our addiction medicine doctor, who is amazing. I've almost learned everything from him over the last 13 years, is if you have patients that are suspected of hepatic impairment, or you notice that the medications are not working, the detox meds, he always taught me